Hello and welcome everyone. Today we are learning about Chandipura virus. Chandipura virus is a member of Rhabdoviridae family and vesiculovirus genera. It is a neurotropic pathogen inflicting high mortality in children within 24 hours of commencement of symptoms. The disease is predominant in lower income strata of population and the affected age group ranged from 2.5 months to 15-year-old. It causes acute sickness and a rapid deterioration, but precise mechanism is not known. In vitro studies have shown increased expression of CHPV phosphoprotein in neuronal cells and their death subsequently by apoptosis. However, more comprehensive studies are needed to confirm the precise mechanism. Phlebotomine sandflies are implicated as a vector due to their predominance in the endemic areas. Repeated virus isolations and their ability to transmit the virus by transovarial and venereal routes. In recent turns of events, there are 23 confirmed cases, which includes states like Gujarat, Maharashtra, Rajasthan, Madhya Pradesh in India till 24 July 2024, with 10 confirmed deaths due to Chandipura virus. History. It was first identified in 1965 in Chandipura, which is a village in Maharashtra state of India. The epicenter of CHPV activity has been restricted to central India, comprising the parts of Gujarat, Madhya Pradesh, Andhra Pradesh, Maharashtra, and Rajasthan. In 2003 and 2004 outbreaks in central India, a total of 322 child deaths were occurred. The disease was characterized by sudden onset of high-grade fever followed by seizure, altered sensorium, diarrhea and vomiting followed by death in majority of cases. The cause of death was interpreted as encephalitis, acute catastrophic event in the brain, spasm or transient obstruction due to vasculitis. Apart from India, the CHPV activity is also prevalent in West Africa and Sri Lanka. CHPV is characterized by non-segmented single-stranded RNA genome of anti-message sense or negative sense. Viruses belong to Rhabdo family. Rhabdo means rod-shaped in Greek or typical bullet-shaped morphology, which is 150 to 165 nanometer long and 50 to 65 nanometer wide. Clinical features. Typical symptoms include rapid onset of fever, vomiting, altered mental state, convulsions, diarrhea, neurological deficits such as difficulty speaking, loss of balance, vision changes, and signs of meningeal irritations, evidenced by symptoms such as headache, stiff neck, sensitivity to light, and seizures. Here are the example of cases. 11-year-old child was presented with a high-grade fever, vomiting, loose motion and developed unusual complications and collapsed within 1 hour of admission. The patient experienced convulsion lasting for 2 to 5 minutes at an interval of 15 to 20 minutes and had a generalized hypertonia of limbs, hyperreflexia, bilateral extensor plantar response with sudden drop in blood pressure. Role of laboratory in CHPV. Elevated levels of interleukin 2, 6, interferon gamma and tumor necrosis factor alpha were observed in CHPV infected children. Immunofluorescence antibody technique and virus isolation using cell line. IFA was successfully employed to detect presence of CHPV in brain tissue during 2003 outbreak in Andhra Pradesh. Subsequently, the IFA was standardized to detect presence of CHPV in cell culture inoculated with field samples. Diagnosis with molecular tools such as reverse transcriptase PCR and real-time RT-PCR. A highly sensitive diagnostic RT-PCR targeting N gene with a detection of 10 to 100 plaque-forming units have been developed, and it is used for routine diagnosis of human and sandfly samples. Development and standardization of one-step real-time RT-PCR using TechMan technology targeting P gene of CHPV has become a major achievement for detection and quantitation of CHPV from field samples. CHPV specific IgM ELISA with specific polyclonal antibodies can be used for the detection of anti-CHPV IgM antibodies in the patient's serum and CSF. Plaque reduction neutralization test PRNT is considered as a gold standard to detect neutralizing antibody against Chandipura virus. However, the test is cumbersome to perform, time intensive, and reading is subjective. Recently developed micro neutralization ELISA (MN ELISA) detect neutralizing antibody against CHPV which has a shorter turnaround time. Vaccines and antivirals. Two vaccine, recombinant vaccine and killed virus vaccine. These vaccine trials have been done in mice. The development of G protein based recombinant vaccine and BPL inactivated vaccine were found to be highly immunogenic, but human trial is not done yet. Similarly, in antivirals, siRNAs are found to be effective in inhibiting the viral replication in both in vivo and in vitro. Despite the therapeutic potential, no clinical trials have been carried out for use in human. Vector control. CHPV is transmitted by phlebotomized sandflies as evidenced by repeated isolations and their ability to transmit virus by transovarial and venereal routes. Spraying of insecticide could bring down the population drastically. Sometimes it is challenging. Control of vector in endemic areas is difficult as they breed in damp places inside crevices of stone used for construction where insecticide spraying is generally not possible. Cow dung smearing of the floor and wall of house is another practice of inhabitants in endemic areas. They accumulate dried cow dung sheets inside the houses as a fodder. It has been reported that a cow dung serves as a feed for sandfly larvae. Conclusion. Currently, there is no specific antiviral treatment or vaccine available for Chandipura virus. Early diagnosis and supportive care such as managing airways, fluid balance, the prevention of secondary bacterial infections are essential for patient management. Prevention strategies include vector control, identifying and eliminating sandfly breeding sites, and using protective measures to prevent sandfly bites such as wearing protective clothing and using repellents and nets. These are the references for this video. Hope you like it. Thank you. Bye. See you in the next video.